Okay, so today is going to be somewhat of a review session. I'll share with you some things that I anticipate putting on the exam. I'll also be finishing up the last little bit over Chapter 21, which was where I got cut off on Tuesday with the last bit of the respiratory system. Some of you walked out of here telling me thumbs up. Some of you people walked out of here on Tuesday saying I'm not quite getting all of this respiratory stuff. So I appreciate that. I'm glad that you were honest with me about that. I want to go back and review some of that. But what I think is best for me to do is just kind of finish up this last little bit. Then we can go back and retell that story. You can ask me where there are specific problems or concerns. And then I also want to share with you a respirometry type of problem that I'll be asking you to do on the exam. And finally, I'll entertain any questions related to the digestive or lymphatic systems. So the exam will be next Tuesday. It'll be a full-length exam. It's going to cover chapters 20, 21, and 22, lymphatic, digestive, and respiratory. Honestly, respiratory is probably the biggest of the three, isn't it? We've spent more time on that. Lymphatic, pretty straightforward. There's no numbers. There's nothing really, I don't think anything really troubling or there's nothing that is difficult to understand about the lymphatic system. It's just learning about those structures. And the same is true with the digestive system. So I would imagine that the respiratory system is the area that most of you are feeling the least comfortable with overall, because it does involve a few numbers and a few other things. So let's just keep going, and then we'll come back and review. So the respiratory system, we've been talking about how the muscles of inspiration and expiration, so know the muscles of resting or passive versus deep inspiration and expiration. You're going to know your different values on the spirometry tracing, and we'll go back and look at those numbers related to the pressure of oxygen and CO2. There were four guys that I mentioned: Boyle, Dalton, Henry, and Bohr, right? Those were the four guys that were mentioned. Make sure you know what each of those individuals contributed to the understanding of the respiratory system. Now, what part of your brain controls this? That's kind of where we're going right now. What part of your brain is going to control your rhythmicity, the automatic breathing? You would not expect it to be in the cerebrum, right? It's not a voluntary thing. The respiratory control center or the rhythmicity centers are going to be located in the medulla oblongata. So within the medulla, there's going to be an area that is primarily responsible for your breathing. You can imagine that it's going to have a lot of sympathetic and parasympathetic innervation because this is an involuntary reaction, and your body is going to, at times, require you to be breathing faster and more deeply than other times. There are in this respiratory rhythmicity center of the medulla some pacemaker-like cells, and you know what that means. It means that these cells have a non-resting membrane potential, that they're going to be triggered to send action potentials at regular intervals, causing you to breathe, but we also have some control over that, right? So we have a complex, if you will, that is going to work in conjunction between the rhythmicity or the autorhythmicity of the respiratory system, but you have some control, right? You can choose to hold your breath for a short while. You can choose to increase your respiration. You don't get to choose that with your heart, do you? I mean, you don't get to choose to slow your heart down or speed your heart up. Yeah, you can exercise, but you can't directly affect the heart like you can the respiratory system. So there is this Boltzinger complex, which is also helping us to breathe, and we don't really understand it all, but I'll throw the name out there as an understanding as we move forward. Now, in the medulla, there are two nuclei. What's a nucleus in the brain? A nucleus in the brain is what? Cluster of cell bodies, right? We know what a nucleus is. It's a cluster of cell bodies, and these cell bodies are in two areas. There is a dorsal respiratory group, and this group of neurons within the medulla are going to be responding or modifying in response to chemoreceptors. Now, chemoreceptors are receptors that are going to be picking up chemical signals. In this case, they are looking at sort of a combination of oxygen levels, CO2 levels, and acidity, pH. And they're looking at the levels of these molecules in the blood as well as in the CSF. So there are chemoreceptors strategically placed looking for CO2 levels, pH levels, and oxygen levels in both your blood and in your CSF. And then there are also some baroreceptors. These are going to be stretch receptors that are monitoring how much you are expanding the lungs along the wall of the lungs. Now this DRG is mostly concerned with your inspiration, causing you to inspire, to take a breath in. Okay? So this is going to innervate. These neurons leaving from the DRG are going to go from the medulla oblongata, and they're going to interact with your primary inspiratory muscles, and you tell me what they are. What are the two primary or quiet inspiration muscles? Which did 75% of inspiration? The diaphragm, right? And the other 25% came from the external intercostals, right? Now, you already can imagine then, these nerves are going to leave from the DRG and go through what plexus? You don't know about the intercostal, but you do know about the phrenic. So you know the phrenic nerve is innervated by the C4, C3, C4, C5. So you're kind of imagining this circuitry. It's going from the medulla oblongata, and it's going to travel down to the cervical plexus and innervate, leave out C3, C4, C5, and innervate the phrenic nerve, right? We kind of can picture this network, this connection from the medulla to the diaphragm. In addition to the DRG, there is a VRG. It's a ventral group, respiratory group, and this group is mostly involved with expiration. Now you know that expiration is, in normal, quiet breathing, expiration is passive. It does not require the contraction of a muscle, simply the relaxation of those external intercostals and the relaxation of the diaphragm. And so this VRG is really only going to kick in when you must have those accessory respiratory muscles. Okay, so normally the DRG is dealing with inspiration. Remember that expiration is passive normally, unless you are trying to blow out that birthday cake and take that big breath in. And the VRG is mostly dealing with regulating your expiration. Now there's also, in addition to those, the DRG and the VRG, there's also an anuistic, I always have to say that word around, the PSI, right, pneumo. So anuistic and pneumotaxic centers. Now these centers are located in the pons, and they are going to be helping to set the pace. So they're going to adjust the output of your respiratory rhythmicity centers. In effect, they're going to pace your rate of respiration. So the anuistic center is going to promote the inhalation by stimulating the DRG. So in other words, this is kind of setting the pace, going to the DRG, and how active this region is going to be based upon vagus. Now the vagus nerve does what? Wanders, right, all the way down and is going from your brainstem all the way down your cranium, all the way down to your internal organs. And the vagus nerve is going down and is sending information back to the pons and to the medulla about how inflated your lungs are. We'll put this all together in a second. The pneumotaxic centers are going to inhibit this other center, and this is going to promote passive or active exhalation. Basically, if it increases the output, it's going to shorten the inhalation, and if it decreases it, it is going to increase the depth of respiration. So let's put this all together into a diagram. Oh, forgot about this. That's all happening in the brainstem, right? That's the medulla, and that's the pons. Do you agree that's not anything we have control over? Autonomic nervous system is talking to these centers, helping to set the pace of our breathing. But as we were saying earlier, or as I was saying, you still have some control over breathing. Now, when I say cerebral cortex, you should be thinking consciousness, right? And so you can choose to breathe deeper, blow out a candle, or breathe faster. When I say limbic system, the amygdala, the hippocampus, that area, right? When I say limbic system, you think emotional centers. Can you emotionally get so distraught that it affects your respiration?
Yes.
Yes, right? So clearly, that's not something we have control over, if you will, but clearly the limbic system can influence, right, your breathing. It's going to speed up if you're stressed out. It may even relax it a little bit if you're feeling happy thoughts. And then the hypothalamus also has some of these centers. So clearly, your emotions and your consciousness can change or alter these breathing control centers. And even if we don't have any thought about your breathing, it's still going to go on, right? So assuming no input from the cortex or no input from the limbic system, you are still going to be able to breathe because your brainstem is going to keep things going at a rhythmic pace. So this is the kind of diagram you got to kind of stare at, learn about a couple new units here and a couple new areas of the brain. So we'll start right here. We've got the rhythmicity centers, and I told you that there were two of these primarily. There was the DRG and the VRG. Well, just as the name suggests, one is more dorsal and one is more ventral. And these groups are going to be, as we said, the DRG. The DRG is sending signals out to the diaphragm and to the external intercostals, right? Those were the muscles of quiet inspiration. The VRG instead was sending things out to accessory muscles, either to inhale a larger amount or to exhale a larger amount. But the VRG is dealing with those areas. So I think before I said it only dealt with expiratory muscles, but the VRG also deals with taking in that big breath. Now those centers are going to be doing your normal breathing. But there's also, in the pons, two other centers, pneumotaxic center and the aneustic center, and these centers are talking to each other. In fact, the pneumotaxic center will inhibit the aneustic center. And the aneustic center then speaks to your inspiratory centers of the DRG. And then there's always that possibility of the cortex or the limbic system also speaking to your breathing rates. So this is minimum, right? Level 1. This is what's happening in the background, quiet breathing, all is good. Level 2, you need to adjust that rhythmicity. You're now going to kick in some higher respiratory function. And then number 3, if you need to consciously or emotionally adjust your respiratory system, you'll do that. Now, if you are about to start exercising, it's interesting, even before you exercise, your brain knows that you're about to begin to exercise and will actually send signals to your medulla and your pons to actually increase your respiratory rate so that when you do start to exercise, the lungs have already kind of started bringing more oxygen to the necessary muscles. So all this is just magically and mysteriously, I shouldn't say mysteriously, but magically coordinated for you. So again, we just look at these different things when we're talking about quiet breathing. Quiet breathing. How many times did I say on average one would breathe? I think one table told us 12 to 18 breaths a minute. But I said to make the numbers work that all the calculations always use, they always use the number 12, which means you're breathing how often? How many seconds for every breath cycle? 60 divided by 12 is and always has been 5, right? 5 times 12 is 60. So what we're seeing, and that's where these numbers are coming from, you're going to be inhaling for about 2 seconds, and you're going to be exhaling for a total of 3 seconds. So there's that 5-second cycle, right? And this is your quiet breathing. And why did I say 12 was such a magical number? 12 times a minute. Every tidal volume breath is how many mils of air? 500. And for that normal, typical 150-pound male, we'll see that the total lung capacity is 6 liters, and the total output of air per minute is 6 liters. So that idea of 12, now that's a norm. That's just a normal number, just to kind of start our conversation. Does that mean everyone in this room is breathing at 12 times a minute? No, right? Just, again, we've got to deal with averages, and like any anatomy and physiology course, we first have to learn kind of normal averages, and then when you step in the clinic, you start learning about pathophysiology and how things all go wrong, and you start understanding how that works by understanding the normal. So again, when we've got the The DRG is going to stimulate inspiration. That's going to be the diaphragm and the external intercostals. That's going to cause you to expand your chest. That's going to allow the atmospheric pressure to push air into your lungs. And then you are going to relax those muscles, and that is going to cause them to relax. It's going to cause the thoracic cavity to get smaller, and that's going to cause the pressure to go up, and that's going to push that air up and out of your lungs. And what law describes that relationship of pressure and volume? Boyle, right? The first guy we talked about, Boyle, is who described this inverse relationship between volume and pressure. And then when we talk about forced inhalation or forced expiration, notice there's no time on this. This could be quite variable. But now we're going to go to the VRG, right? That was the ventral respiratory group. And it's going to kick in when we want to breathe heavier or blow out more. And that's going to increase the activity of those accessory muscles for inhalation and the exhalation, the extra muscles involved with that. Now remind me, what were some of the other accessory inspiration muscles? When you want to take in that biggest breath, what muscles get involved? Why don't you guys look, right? Take a look. Look back. What page is that? Or how many pages back is it? Yeah, the scalenes. Where are the scalenes? Side of the neck. What are they doing? They're kind of raising up the first rib or so. What else gets involved? Intercostals. Which ones? Internal, right? The externals are already involved in quiet, right? So the internals get involved. Who else gets involved in making the chest bigger? Weren't there two more? Did we have the pec minor and the serratus anterior? Am I making this up? Okay. Why do I know this? You should know this too, right? Okay. So, serratus anterior, right, the pec minor. And then when you want to forcibly blow out, you're going to recruit what muscles? Blowing out is going to require some rectus abdominis. It's going to require some oblique muscles, right? What else? Was there anything else on that list? Yeah, transversus, which we didn't even know. You don't know what that muscle is, so I wouldn't worry about that one. You'll recognize it, but we don't even know what that is, do we? What else? Wasn't there one more? SCM, storocleidomastoid. Is that in there? Yay, okay. I get an A, good. Okay, so remember, those muscles are being activated by what? Not the DRG, but instead the VRG. And then what is setting this? Okay, what is going to set this in quiet respiration, or even when your body is demanding you breathe more or to breathe less frequently, you're going to be changing this reflex, right? By the very word reflex, you know it's something you don't have complete control over. It's involuntary. And we're going to be changing our respiratory rate based upon chemoreceptors and baroreceptors. Now, where are the baroreceptors? I think they came by in our conversation about the heart. Okay, where were the baroreceptors related to blood pressure? Just as a reminder, tell me. They were found in the carotid, sinuses, and also in the aortic arch, right? Okay, and now we have those same baroreceptors are also going to be informing your respiratory system. So as you have more blood coming into the aorta, or more blood going up into the brain, and stretching those vessels, that will also activate or alter the activity of these respiratory centers. Stretch receptors are also going to be located in the wall of the lungs, like I said, and we're going to be checking out the pH of the blood and of CSF. Now, when I say the pH of blood, what's the normal pH of blood? 7.4. And what magical molecule did we discuss last time that is going to cause the blood pH to drop? CO2, right? So when I say CO2 levels and pH, do we understand the connection? That as CO2 levels rise, the pH would go down, right? As CO2 levels decrease, there could also be a corresponding increase, right, in the blood pH. So we're going to be seeing this balancing act between CO2 and how well the body can get rid of CO2. And by getting rid of CO2, you're also helping to balance your pH levels. Okay. I should also say that any kind of irritant within the bronchial tree can cause you to sneeze or to gag or to cough. That's also related here, isn't it? All that's also a reflex helping to protect your lungs from possibly aspirating something down into the more delicate tissues. So let's talk about these chemoreceptors. Under normal conditions, do you remember what the normal conditions are? In your blood, go back. What would be the normal PCO2 in your, let's go with your arterial blood? What was PCO2 traveling through arterial blood? Didn't I give you number 40? Okay, and then after that blood went to the capillaries and dropped off oxygen and picked up CO2, that PCO2 is going to be bigger, isn't it? So in the venous blood, what should PCO2 be? It went from 40 up to 45, 46, right? Do I get an A? 45? Okay. 45, 46, somewhere in there, different books. That would be the normal situations, right? PCO2 of 40 in the arterial blood, a PCO2 of 45 in the venous blood. Now, again, if that PCO2 is going up, what's happening to your blood pH? More CO2, lower pH. Less CO2, higher pH. It will be inversely connected. So, under normal conditions, the most important thing that is going to be influencing your respiration, determined by your chemoreceptors, will be how well your CO2 levels are being controlled. If your CO2 levels are well controlled, your respiration will not be negatively affected. If your CO2 levels begin to rise, what do you think it's going to tell your VRG to do, right? Your DRG just hang in, that's your background. But if your CO2 levels are beginning to rise, that means your chemoreceptors are, they're going off, and your pH levels are going too low. What do you think your VRG is going to do for you? Is it going to increase or decrease your respiration rate? Increase, right? Because now what does your body want to do? If you're increasing too much CO2, your body wants to do what? Get more oxygen in and blow more CO2 off, right? Does it make sense? Don't make this hard. This is common sense. If CO2 is rising in your blood, your body is going to want to get rid of it by blowing out more often and trying to get more oxygen in. So here's the deal. Only a 10% increase in CO2 will double your respiration rate. This is a pretty tightly regulated system. It doesn't take much of a difference in the PCO2 to cause havoc, right? Or to really send your body into overdrive when it comes to respiration rate. If your PO2 levels drop, now let's talk about PO2. These things are all connected. What was the normal PO2 coming down your arterial blood, heading toward a capillary? 95. And after it drops off that oxygen, now the PO2 is leaving oxygen? 40. Okay. So, look what it says. PO2 levels have to drop below 60. Now, this is on the arterial side. Okay? So, normally they're where? 95? They have to drop way down to 60 before they trigger the respiratory center. So, in other words, what I'm saying to you, what is more important to triggering your respiration? CO2 fluxes or O2 variations? CO2, right? CO2 is the key. Just a little bit of change in CO2, your respiratory system is going to go bonkers trying to adjust for it. It takes quite a bit of oxygen differences for it to trigger the respiratory centers. Another way of saying an increase in CO2 is to say hypercapnia. Hyper, more, capnia is referring to the CO2. So hypercapnia is an increased CO2 level, an increased arterial CO2. Now, why would this mostly happen? There's a few different reasons why one would have too much CO2. One is hypoventilation. What does that mean? Hypoventilation. Not breathing adequate amounts of oxygen, if you will. And if you're not getting enough oxygen in, what's going to happen to your CO2? Right? Not enough oxygen in, CO2 will build up. So that would be one reason that would cause hypercapnia. You also could increase in PCO2, will stimulate the chemoreceptors. Those chemoreceptors are then going to tell your body to increase the respiratory rate. So in response to hypercapnia, your respiration rate will go up, right? Because, no, it's good. If you have too much CO2, your blood pH is becoming more negative or going down, more acidic, and so you would also be acidotic, right? So hypercapnia, too much CO2, for the purposes of our learning, would usually be associated with acidosis, right? There's some variations on that theme, but we're not going to go there, right? So typically, right, too much CO2 would cause your blood pH to go down, and you would be acidotic. What about hypocapnia? Flip it, not enough CO2. Your PCO2 has gone down in your arterial side. This is mostly caused by hyperventilating. Okay, hyperventilating. Breathing too quickly. If you're breathing too quickly, what's happening? You're getting rid of too much CO2, right? So why do we tell someone who is hyperventilating to blow into a bag? What are they actually breathing back in? Right? So they're breathing back in their own CO2. Because if you're hyperventilating, you're blowing off too much CO2, and that's going to make you have a lower PCO2, right? And your blood pH is going to go up. And the best way to fix that is give them a paper bag. Let them breathe in their own CO2 to sort of help correct that overblowing of the CO2. So what's going to happen? In response to a low CO2, now the body will start slowing down its respiration rate. So when you give that person the paper bag, after a while, it starts to slow down. Not only are they, quote, calming down, but it's also having an effect on their VRG. So their overall respiratory centers are cooling it, they're calming down as their PCO2 returns back to normal. And also, snorkelers sometimes will hyperventilate to increase a dive time. So it can be very, very dangerous when you have a problem in diving. And I've only been snorkeling. I've never been scuba diving because I really can't tell which way's up. So they told me never go scuba diving. And if I ever should go scuba diving, follow the bubbles. Well, I'm already thinking, okay, where are the bubbles coming from? If I'm underwater and I can't figure out which way's up, I'm supposed to blow out all the air I have and follow the bubbles? Basically, they're telling me, don't do it, right? Because I can't tell up from down when I'm in the water. So, not a good idea. And, but it is possible that oxygen levels can drop quickly and cause a fainting, a blackout in some snorkeling and underwater things. So let's take a look at this. Let's make a sense of this whole story. So again, we want to keep our homeostasis. We want to keep our normal PCO2s. Our normal arterial PCO2 is what again? Put a number on this. 40, right? That's what we wanted to keep it at, or about 40. If for some reason there's a disturbance in the homeostasis and that PCO2, and I should say arterial PCO2, goes down, now you have hypocapnia. And your body will do what in response to that? It will inhibit those chemoreceptors because now the pH is doing what? Decreased CO2 will cause what to the pH? It's going to go up, right? And this is going to go up not only in your blood, but also in your CSF. Okay? And so what's going to happen? You're going to inhibit your respiratory muscles. You're going to decrease the stimulation. And overall, you're going to slow down the elimination of CO2 and help restore it back to normal. Vice versa, if instead you have an increased arterial PCO2, so it's going up above what? Above 40, right? You have hypercapnia, then you're going to stimulate, you're going to have more acid, you're going to stimulate the chemoreceptors, and that collectively is going to cause you to start breathing more quickly and increase your respiration rate. Does that make sense? You've got to be able to follow that wheel around and think about if this goes up, what goes down? If this goes down, what goes up? It really is what's necessary. That's the chemoreceptor side. The baroreceptor side, similarly, you've got like a couple of different sets of backup alarms is the way I think about it. So the baroreceptors are now going to be monitoring your blood pressure in both the carotid and the aortic sinuses. Okay, let me ask you this. Which cranial nerve, I'm going to tell you right now, cranial nerves 10 and 9 are involved here with baroreceptors. Which one, 10 or 9, is involved at the aorta? 10, right? Because we know the vagus goes down to the heart. Check. So the vagus nerve is the one that's sending this baroreceptor information from the aortic arch. The 9th nerve, the glossopharyngeal nerve, is sending information from the carotid sinuses. And again, as the blood pressure is being monitored, it's also not only going to affect the heart, but it's also going to affect the lungs. If there's a drop in blood pressure, it's going to stimulate your respiratory centers and cause an increase in your respiratory volume. If instead there's an increase in pressure, if there's an increase in pressure, then it's going to inhibit your respiratory centers. Okay. So again, you've got this balancing act of blood pressure, respiration rate, needs of oxygen for the body, eliminating CO2, and we'll see in the next unit how the kidneys are also going to kick in. We'll come back to this chemo and baroreceptor story as we talk about how the kidneys are also involved with regulating blood pressure, but we won't go there yet. That's why the kidneys always come at the end. They really are kind of central. Once we understand the heart and we understand the lungs, then we can better understand the kidneys. Now, there are also baroreceptors, stretch receptors along the lungs, and those are going to be activated when you are forcibly breathing. So if you're really breathing heavily, those are going to go to the VRG and to the aneustic center, and those are going to kick in your inflation reflex. Now, what you don't want is you don't want to overexpand your lungs. Now, normally we couldn't do that, but again, there's a reflex there. Just like you don't want to overextend a joint space, you don't want to overextend a ligament, you also don't want to overstretch the lung. So there's a reflex there to assure that it won't happen. So should the lungs start getting, quote, overexpanded, then there will be a deflation reflex that will inhibit the expiratory centers and stimulate inspiratory centers so that you're not going to over-deflate or over-inflate. So there's inflation and deflation reflexes. So just looking at what's involved here, number one, stretch receptors located smooth muscles around the bronchioles are stimulated by lung expansion. And if it gets to be too much, it will go back and speak to, right, it'll speak to the DRG or the VRG and try to eliminate the possibility of the lungs being overinflated or underinflated. So either one. Okay, just a reverse situation. So these are all protective reflexes, as is coughing and sneezing. These are also triggered by potential irritants coming into the respiratory system. Something comes into the nasal cavity, will sneeze. Something comes into the oral cavity or the trachea or the bronchi, will start to cough. They both involve a period where you're not going to be breathing. So then after you do that, you're always going to have a forced exhalation. And that forced exhalation is going to help clear those irritants. Okay, so it's just all part of the protective reflexes that are in place in our respiratory system. And we'll finish up with what happens as the respiratory system ages. Like everything else, it starts falling apart. Things start to decrease with age. So the elasticity of the lungs will begin to decrease. What's another word for that? If their elasticity decreases, they become less compliant, less stretchy, less compliant, less elastic, right? All those things would be happening. Now, if your lungs become less compliant or less elastic, what will happen to your overall tidal volume? Tidal volume may not change very much because tidal volume is just a small part of your lung capacity, but you would no longer be able to breathe in as deeply or blow out as completely, right, if the compliance begins to go down. I don't think there's a huge difference in the tidal volume with age. I don't think so. I'm looking at my RTs, right? So I don't think there's a big difference in tidal volume. The vital capacity, capacity definitely does decrease, right? The ability to suck in and blow out forcefully would definitely decrease as we age. Arthritis in the ribs can certainly decrease the compliance and certainly affect the volume rates. And emphysema will also certainly do that. Smoking is a great contributor to this decline. The more years you smoke, the more the respiratory function will be decreased over time. So if you look at a graph like this is showing respiratory performance. This is percent of value at age 25, if you will, of people who have never smoked, those who stop smoking, or regular smokers in the red line. So we see by age 75, right, they're down. Well, there's death right there, okay? So they're down as far as function goes. This graph is defining about 30% of respiratory function as being significant enough to cause what we would call disability. So by age, where are we? Somewhere around age 70 or so, you can expect a person who's been smoking for quite some time to really have a decreased respiratory function. Now, if they stop smoking at age 45, then that can be extended through pretty much a normal lifespan. Or if you stop smoking even at 65, it'll expand, respiratory function. So it's never too late to stop, but obviously the earlier you stop, the better off you'll be, and even better, never to start. Okay. Here's my public service announcement. Yes?
What about secondhand smoke on that?
Second, yeah, that's becoming a bigger issue, isn't it? We now know, and even tertiary smoke. What's that? Tertiary smoke is when students hand in their papers to me, and then my house smells like their house, right? I mean, I can tell smokers because when they turn their papers in, their paper reeks of smoke, right? I don't even have to be in the same room with them. So that'd be more of a tertiary, and I don't think that's been shown to be a big problem. But yeah, secondary smoke certainly is. I mean, people who worked in bars and restaurants and people who were flight attendants in the old days when you could smoke on the airplane, that was like horrible, right? There was a non-smoking section and a smoking section. And all that separated the two was a seat sign. Behind this point, it's smoking, or vice versa. And in front of this sign, it's non-smoking. It was a sign. And if it was a really fancy airline, it was a curtain. Well, that's very effective. Right? So, I mean, there really was no place to go on an airplane to get away from that smoke.
How does e-cig smoke play in all this?
There's a lot of papers that are, well, you're hearing more about it. It's not, it's almost yeah. Yeah, it's not an improvement, okay? Don't be fooled. It's not an improvement. Yeah. Okay. Almost worse. In what way is it worse? I didn't know it was worse. I just knew it wasn't any better.
They came out with something saying that even though it's just inhaled vapor, they're still going out that nicotine. But I'm not sure if it's worse for them or the people that are around.
Okay. But clearly the lung is being irritated.
Yeah.
And that's going to, set up, I mean, that's not normal. That's going to set up some disease states with time. No doubt about it. Yes?
My dad, he'd always use the e-cigs and he tries to quit, and every winter he used it, it put more water in his lungs so he'd get bronchitis and pneumonia from it. So he stopped with that, and now he's back to regular.
That's a good point. So yeah, you're definitely drawing in more moisture with that. Yeah, that's another, yeah. So if you already have any kind of respiratory distress, that would probably make it even worse. Or prone to pneumonia, prone to bronchitis. Yeah. Okay. So just don't start, and then it won't be a problem, right? Okay. Lung cancer. Okay, we hear about it all the time. More deaths per year than any other type of cancer. Kills more people than colon, breast, and prostate cancer combined. Big deal. Over 50% of lung cancer patients will die within a year of diagnosis. Okay, so it's not a good diagnosis. The numbers are actually, I just heard about this. I don't want to say it wrong. I think the numbers are dropping a little bit, but not significantly. Of course, it depends what report you're reading. But most, not all, but most lung cancer has been linked directly to smoking at some point in one's life. So even if you stop, you could have smoked for 10 years and stopped, you're still at a higher risk for cancer in the future, less, but still higher than the normal population. The person I always think about who had lung cancer was Christopher Reeve's wife, right? I always think, what a tragedy, right? He dies at 52 from a decubitus ulcer, right? He dies of a bed sore on his butt from a wheelchair, and she dies shortly thereafter of lung cancer, never having smoked. So there's just double whammy. So looking at the numbers, incidence of lung cancer, right? Males coming down, females still going up, or at least plateauing. So what's going on here? There are some carcinogens, some cancer-causing agents, but also the mucus, your goblet cells and the cilia just get pissed off from that constant irritation. And basically there's a metaplasia that occurs. And the trachea is no longer lined by the same cilia. So you don't have the effect or the help of the cilia. And here's that secondhand smoke, the fact that there's definitely a dysplasia or a changing of the cells along the trachea, and that's not only primary, but that's also secondary smoke. Definitely can contribute to that. So the word here is dysplasia would be a irreversible change, or sorry, dysplasia is a reversible change, whereas metaplasia is reversible. But if it gets into a growth like a tumor, then those are an irreversible type of change to the tissues. So don't do it. Don't do it. And that brings us to the end of the respiratory. So I want to go back, and I was sort of alluding to some of those numbers. And let's go back and get these numbers in our head, because these numbers really are very important to understanding all that's going on. I'm going back shortly before I started today. There they are. There's a good place. Where are we? This is figure 21-12 in your book. Is there a page number to help us on this? Or how many pages back it was? It's on the bottom right-hand side. Yep, it's on the, or the top right, okay? You'll see the hemoglobin down the lower right-hand side. So here are the numbers. So as the pressure of oxygen coming into an artery, right, coming into a capillary bed, this represents the capillary bed, and 95 millimeters of mercury, right, coming in, a little bit less than 100, really high, and PCO2 is at 40. After we've done the exchange of gases in the capillaries, O2 is jumping over to your cells in the interstitial fluid. O2 is now going to be less. O2 drops down to 40. There's quite a bit of oxygen that's dropped off in the tissues. PCO2 is coming in at 40. It's picking up CO2 in the capillaries and is now going to be about 45. Now, what has to be true in the interstitial fluid? In order for oxygen to go from the capillary into the tissues, there must be a concentration gradient. And so we're going from 95 to where it's about 40. And in the interstitial fluids, the cells are always making CO2. There's about 45 millimeters of mercury out in this fluid. There's only 40 over here in the blood, so that's going to bring CO2 into, by diffusion, into the blood. No, that's down to the tissues, isn't it? That's down to the tissues, and what we're kind of showing is internal respiration, right? The taking of those gases or receiving of those gases as a result of cellular metabolism. That's the internal respiration. Let's also go back up to external respiration, and this is what's happening. Put these together. Imagine these are side by side. This is what's happening in the alveolus, right? So you've got all these little 300 million of little air sacs, and that's what's represented here on the right side. So here's an alveolus. You just brought air down from the atmosphere. We're going to say that PO2 is 100 within the alveolus. What was it? This is the same number we just saw a moment ago. Leaving the capillary, what was PO2? Right? 40. So this is that same 40. It's coming back in the venous blood. And it comes back, it's been brought back to the right side of the heart, and pumped now over to the lungs. And it comes in, and there's PO2 is 100 in the alveolus. It's going to jump over by diffusion into the blood and reoxygenate that blood. Reverse it. PCO2 was 45, leaving the tissues. It comes back to the heart into the lungs. And here in the atmosphere, there's less PCO2 at 40. So again, the movement of CO2 will be out of the blood into the alveolus, where you'll then expire it. Once the gases exchange here in the pulmonary capillary, PO2 is 100. Now what happens between here and getting down to the tissues? This will drop down a little bit to what we started off at 95 in the previous picture, and the PCO2 will hang out there at 40 until it comes down around to your tissues. Do you see how these two slides, this one and the one I just showed you a moment before, are part of the same story, part of the big loop? Yes? And those numbers are important. So you got about 6 or 7 numbers you've got to grab onto and put some normal numbers to. Any questions about this whole gas exchange, or how is it that your body maintains its respiratory rates? Anything about that? In a moment I'll go to spirometry, but is there anything about just the overall number game here? Is it making sense? Do we have some memorizing to do and some work to do? I hope. But does the story make sense? If the story makes sense, you can go back and plug the numbers in, right? If the story's not making sense, then it's not going to happen. So as long as the story is making sense to you, the overall big picture, then plugging in some numbers to this should go well for you. I want to go back a little bit. Who was the guy that said all of the pressures add up together to make atmospheric pressure? Dalton, right? So just a reminder about Dalton. Dalton said that all the individual pressures of nitrogen, of oxygen, of CO2 combine to make the overall atmospheric pressure. So we just add them together. If there's 78% nitrogen, that means that 78% of the pressure is coming from nitrogen. If there's 21% oxygen, then 21% of the pressure that we experience in the atmosphere is coming from oxygen. Okay. And then what did Henry say? Henry talked about the solubility. When you push gases into a liquid, which gas, CO2 or O2, is more soluble in water or in plasma? Which one dissolves more easily in plasma? Am I hearing CO2? Right? There's quite a bit of CO2 dissolved in your plasma, whereas O2 is rather resistant to dissolving in water. So there's less O2 dissolved. That was Henry. And then the last guy was Bohr. What did Bohr tell us? For Bohr, we're looking at the dissociation curve. And Bohr said that pH of the blood had an effect on how well oxygen bound to hemoglobin. So what happens as the pH goes down? I need you to think about this from another way today right now too. If the pH of your blood's going down, what's going on? If this was, right now you're in a blood vessel and the CO2 levels are rising and the pH is going down, what do you want for your tissues to experience? You want them to have more oxygen. So Bohr said that's how the body works. As the pH goes down, aka CO2 levels are rising, O2 can more easily jump off the hemoglobin. So what we see is that when the pH goes down, right, the normal 7.4 is purple. When the pH goes down to 7.2, it shifts this curve to the right, which basically means that the hemoglobin will release more oxygen. That's a good deal, isn't it? Because your tissues are basically not getting enough oxygen. They've got too much CO2. Does that make sense? If you just think about Bohr, right, this seems boring, But does it make sense to you that as the pH goes down, the body would want to get more oxygen, and that's going to, kind of in a teleological way, allow now the hemoglobin to release more oxygen into the tissue. If instead the pH was going up, that would suggest what? Too much oxygen, or plenty of oxygen, and not enough CO2. So what's hemoglobin going to do? Hold on to it. Right? It shifts to the left. So if it shifts to the left, it's more stingy. It's going to hold on to the oxygen more strongly and not let go of it. So don't memorize a curve, right? Make sense of this, and then it'll follow through. So hemoglobin is going to deliver oxygen when it needs to. Put it that way. And Bohr said that. Let's go back to respirometry. And then I'm going to show you a problem. This is going back to the volumes right here. I'm going to ask you some questions, and based upon this, you're going to give me the answer. Can you all have this page? Go back a few pages. I want this in front of you. You got a graph in front of you. So looking at this particular graph, which represents normals, but it could be a patient. Let's say a patient just walked in. They did what's called pulmonary function tests, and basically we measure many of these things by a person blowing into a mouthpiece and recording these numbers, and you'll be doing some of that next week in lab when we do some respiratory function. What is this person's tidal volume? Don't throw out the average number, but I want you to read the chart. They happen to be the same, but regardless, looking at this chart, what is the person's tidal volume? I'm hearing 500, and we always have to have units, milliliters. How did we get 500 milliliters? If I were to give you a problem like this, and I gave you a spirometry tracing, and I gave you all the numbers along the axis like you see, and I said, what is this person's tidal volume? You would have to do what? Look at the 2700 and look at the 2200 and subtract the difference. So the tidal volume represents this 500 mil influx, outflux, right? Quiet respiration. What is this person's inspiratory reserve volume? First of all, where is IRV, inspiratory reserve volume? It is this, right? It is the amount of air that you would breathe in above your normal inspiration to the maximum that you can breathe. So on this graph, what would this patient's IRV equal? I heard it, but I didn't only hear it from one person. 3,300 milliliters or 3.3 liters. Where did we get that number from? If I just read the chart, right? Just read the chart. The maximum, the top of the IRV is 6,000. And the IRV is this area here from the top of the vital capacity to the top of the maximum inspiration. The difference between 2,700 and 6,000 is 3,300. So the IRV on this graph for this particular person would be measured at 3,300 mils. What is this person's ERV? What is ERV? ERV is the amount of air that you could forcibly blow out beyond what you would normally breathe. That is represented here. I look at the graph, and it tells me that that is the difference between 2,200 and 1,200. So this ERV is 1,000 or 1,000 milliliters or 1 liter. What is this person's vital capacity?
6,000 or 6 liters. The vital. Oh, that's the title.
Mm-hmm.
Sorry.
Not tidal, but vital capacity. What is vital capacity? how much you are able to breathe in from your maximum down to your biggest blowout, right? So vital capacity is from your biggest breath to your lowest expiration. Looks to be 4,800. Does everyone see where I'm getting those numbers? I want you to have an idea of what these numbers are, but I also need you to be able to read a graph, right? And if I were to give you a patient and asked you, what is the IRV, what is the ERV, all you would need to do is read the numbers on the graph. Okay, so I don't want you to plug in normals, I want you to plug in the actual value. I could give you a 4'8" woman's spirograph, right? And it's not going to be a 6 liter total capacity. It's going to be a much smaller lung. And so for that patient, read the graph and tell me what would the vital capacity be, what would be the tidal volume, what would the IRV and the ERV be? And then I saw another hand as well.
Are the things going to be labeled on there, or are we going to be able to differentiate?
Okay, so the question is, would it say this is vital capacity? No. You're going to need to know that vital capacity is the IRV plus the tidal volume plus the ERV. That you just need to understand in your head. Okay? So the graph would have the numbers on the side, the graph would have the curves, and then you would have to use the axis to determine the value, the number. I saw another hand.
Oh, it was more like, is it gonna be color coded?
Would it be color-coded? No, but you'd be able to see the lines and see the... In fact, I was going to show you the exact question from the test, and I was going to pass it out, but all the printers on campus have been down for 2 days. So I wasn't able to provide that for you, but let me just do this, you know? I'm going to do this. This may not be the exact problem on the test, but Dr. Google, I'm going to talk with Dr. Google here for a second. Oop, that won't do it. Oh, come on. Your test would look more like... Oh, lovely. Okay. Can you guys see this at all? Where am I looking? Where is it? There it is. Look how easy it is to make a test. Okay, now, but you know what this doesn't show? It doesn't give the numbers on the side. But if it looked like this, right, you would need to know what is what. So you tell me, which one is tidal volume? Number 1. Which one is ERV? 3. Which one is IRV? 5. Which one is vital capacity?
6.
Which one is total lung capacity? 7, you see it? Which one's residual volume? 2. What is residual volume? After you blow out as far as you can, there's always some air left behind. Okay? And if there were numbers over here, you would estimate the numbers just simply by reading the graph. What do you think? David, handle it? Yeah. It requires addition and subtraction. Okay, now, so let me go back then. Maybe I can find another one. So that's a good example. I just wish they had one with numbers. I saw one with numbers just a moment ago.
How are these things measured?
How?
Yes.
You blow into a device that can measure the airflow, and it can measure also a 1 second airflow. We're going to talk a few more specifics in lab next week. You'll learn more than this in lab. But if you walk into lab next week understanding the basic IRV, ERV, tidal volume, you'll sail right through lab. But you basically blow into a mouthpiece that is connected to a computer that can measure the volume of air being blown, just breathing comfortably, as well as how much air you can forcibly blow out or how much you can forcibly inhale.
Is the residual just like a...
Residual you can't measure. I can take I'll show you in lab. There are charts that you can say, okay, this person is 6 foot tall, he's male, and he's 45 years old. And from that data, you can determine what their lung capacity should be based on norms, and then you can actually perform the test and see if they're reasonably normal or not. But we'll get to that in lab. I'm not going to go there to the disease states with you here. So anything about respiratory? More about respiratory that you're concerned about? What do you think? Anything? What about lymphatic? Go back to your chapter 20 notes. That's the one I handed you. If you never got those notes, there's still some outside my office. But chapter 20 notes. What is it about the lymphatic system that is causing you distress? That one you've kind of done. You're done with that one, right? Essentially, the quiz is over. The homework is over for that. And so that one, was there anything in the quiz or the test or the homework or anything that gave you stress, conceptual issues? The collecting ducts?
I guess I'm having a hard time understanding. Are they draining the side that they're on or the opposite side?
The efferent, afferent, you mean the efferent, afferent in the lymph node?
Like the thoracic duct.
Okay.
And the lymphatic ducts.
So
There
all,
were questions that tried to get you to be able to tell which side, and I guess I got confused to the point where I thought that maybe they were draining opposite.
well, the thoracic duct is receiving a very asymmetric drainage, right? So everything from both legs, the whole trunk, and what side of the body? The thoracic duct, right? It's on the left side. So that's your left arm, left shoulder, left face, left head. All that is coming in through your thoracic duct. And what we don't see here, all those lymphatics are one ways. That's totally different from arteries and veins, isn't it? Arteries and veins create a circular closed pattern amongst themselves. The lymphatic vessels have those fenestrated ends and are one-way vessels. And all those lymphatic capillaries start merging as they go through the lymph nodes, and they all merge into larger and larger vessels until they all drain into the thoracic duct, and then the thoracic duct drains into what? The left subclavian. And the right lymphatic duct will drain into the right subclavian. And I really do wish they were just right and left lymphatic ducts, but they just didn't name them that way. The thoracic duct is the left side and is, both legs. And then you have the lymphatic duct, the right lymphatic duct. I'm not sure that answered your question completely or not.
I think so. So what you're saying is all of the lymph or all of the lymphocytes are coming basically up the body to the collecting ducts, which then they're pumped into the
Back into the venous system.
and then they're brought back down through like the rest of the body, through the veins, and then
Yeah, there you go. So as all this lymph, because what is lymph? Lymph has 3 different names depending upon where it is. Lymph is lymph when it's in your lymphatic vessels. That same fluid is called interstitial fluid when it's in between the cells of your tissues. And that same fluid is essentially the same thing as your plasma when it's located in your blood vessels. So you're percolating, your blood is being filtered by your spleen, right? The spleen does the same job as the lymph nodes for the blood. The capillaries are exchanging lymph and interstitial fluid and plasma, and that's being percolating through all of these lymph nodes up through and into back into your thoracic ducts. And that's going to come back into your subclavian veins, Subclavians are going to merge into what? Subclavians are going to merge with the jugulars and then become the brachiocephalic veins, and the two brachiocephalic veins will then merge to become the superior vena cava. So you're just bringing blood back into, right, blue blood, if you will, coming back in. All that lymph has been filtered and is now entering back now as plasma. So the moment this stuff goes from the thoracic duct into the vein, it's changed its name, hasn't it? It's gone from being lymph to plasma.
That clears it up.
Good. It's more of a conceptual thing. I don't think there's anything really difficult here, but there is some conceptual. You have to imagine this, and you have to get on that little magic school bus ride, and you've got to go down to the capillaries. I mean, you have to imagine this. You have to imagine the intertwining of the lymphatic capillaries with the capillaries, right? And that they're running together, and that's not even the picture I wanted to show you. This one, right? This is what you need to be able to imagine. You have to imagine that the blood is coming in arterioles, is coming into a capillary bed. Remember, about 85% of the fluid that is pushed out into the interstitium is reabsorbed, right? Remember the story? Is reabsorbed at the distal end of the capillary. That 15% that is sitting out here in the tissues is then picked up by the lymphatic vessels that are sitting right there. And they're going to be carrying that fluid away. Remember that story? But before, we didn't have the lymphatic vessels in that story. So you're like, oh man, how's that working? So when I described that to you before, we didn't really have the lymphatics in focus. Now you have realized where that 15% of fluid is going. It's being sucked up by these lymphatics. And if there's a blockage in the lymphatics, right, then you'll have edema. Because the capillaries are going to keep doing their job, aren't they? The capillaries are going to keep doing exchange. And that fluid is going to start building up. Now, at some point, if there was dramatic edema, I would imagine there'd be enough hydrostatic pressure pushing back that there wouldn't be a constant, more fluid coming in at the same rate. But you would still have this exchange of fluids happening, because without fluids, you wouldn't have glucose. Does that make sense? If your fluid levels are not moving out of your capillaries, you're going to be carrying glucose and other nutrients with that water. So you really would never be able to stop sending water into your tissues. Even if your lymphatics were badly damaged, you still need to have fluid movement to get nutrient movement. I forget who asked that question, but hopefully that's starting to come together. So we're okay with okay, go ahead.
Will it be like labeling diagrams?
There'll definitely be some labeling diagrams, absolutely. It'll be mostly multiple choice. I suspect the spirometry, I don't know if the spirometry will be multiple choice or if it'll be fill in the blank, right? It might just be, here's a spirograph, right? The numbers and just what are the numbers, write them down below. Or it might be, here's the diagram, the number is one of these 5 down here, A, B, C, D, or E, okay? But either way, you just have to be able to subtract the numbers or add the numbers. Then how about the digestive system? That's the presentation. You've had an hour on the digestive organs and then about a 40-minute or 30 or 40-minute presentation over the last little bit of that with the accessory organs. Was there anything about the gallbladder, the liver, the pancreas that I discussed that was troubling, or anything about the enzymes released by the stomach, gastrin, or secretin, CCK? Each of those did what? Each of those hormones was activated by, or secretions was activated by something else, wasn't it? So like fat in the gut is going to cause more CCK, right? So different, and then CCK is going to tell the gallbladder to squeeze and release more bile. So there were some signals that I wanted you to appreciate related to the digestive system. Was there anything in that conversation? Now that quiz, that was the last thing. I made that last because I wanted to give you the chance to catch up on those digestive lectures. And the last quiz and the last homework are related to digestive, and they're both due on Monday at midnight. Is that correct? That's what I remember doing. So that means you're going to be able to go back after Monday at midnight and review the digestive quiz. You already can review your answers on the lymphatic quiz, and the respiratory quiz is due, anybody recall? Sunday?
Can you go through to the pathway, switching
Pathway for?
of the lymph through the lymph node? Do we need to know those?
Sure, yeah. So, let me think,
And
that's,
the do we need to know what, like the location of the B and T cells in the lymph
Well-
node, or?
let's take a look. That's before this, isn't it? So I think, Roxana, your question is just the flow of fluid through the lymph node?
Yeah.
It is further down. So we have the afferents and the efferents, right?
Yes.
Okay.
Yeah.
So, I missed it altogether, didn't I? If you see it, let me know. That's the spleen. There's the thymus. There's the lymph node.
There, there.
Okay. So, what I want you to realize is that as that fluid is picked up at the capillaries, I mean, millions of these little lymphatic capillaries, every single one of your capillary beds has a little lymphatic capillary, right? They're always going to be found together. And this fluid is being picked up, and it's going to eventually drain through capillaries, or through these lymphatics to the lymph nodes. Now, where do you have the most concentrated lymph nodes? 3 places. Cervical, axillary, and guinal, right? 3 regions where there's more, but they're everywhere. And the fluid is coming in from many of these little capillaries, these lymphatic capillaries. Those are called the afferent, okay? And the term lymphatics, you could put in there lymphatic vessel or lymphatic capillary. And then it's coming in, and what's it doing? Inside, it is intermingling. This lymph is now able to go through this trabecular area, this area where there's a lot of interaction of the T cells and the B cells and the lymph coming in, so that you have greater opportunity for destruction and for identification of these molecules. So it's going to come in, it's going to go, there's going to be some dendritic cells that'll be kind of right at the beginning of that. Those are some of the attacking phagocytic cells. And then it will go to the outer cortex. And what did I tell you was in the outer cortex? T cells or B cells? B. And they make the antibodies. And then it's going to go from out toward the in. So it's going to go to the deeper cortex. And it's in the deeper cortex that there's going to be more T cells. So we're going to be going by antibody-producing cells, and we're going to be going by T cells that can directly attack and destroy. And so we're going by both of the major components of the immune system, and then it's all going to flow into the sinus, and then eventually, again, it just kind of flows back into these efferent lymphatics. And there are some valves here, so that fluid can only move in one direction, because the lymphatics have the same problem that the veins do. There's not much muscle, they're very weak, they're under low pressure. So we also have valves along the way. Again, as you move your muscles or massage, you're moving fluid through those lymphatics. And so, again, movement is important. Another thing to help with lymphedema, if you have swollen ankles, is to walk. But when you have swollen ankles, it's more painful to walk. So it's one of those catch-22 things. But movement of the muscles is actually going to increase lymphatic flow and decrease the swelling if you have any kind of swelling like around your ankle. And a person who is more static, right, the person who works at Walmart and is a cashier all day and doesn't get to move very much and is not using their leg muscles, but they're standing up, is more prone to having fluid around their ankles and more puffy ankles because, again, the lymphatic drainage and the venous drainage is not as great without the muscle movement. Does that help, Roxana?
Yeah.
Okay.
So, like, the only purpose of the valves is just
Keep
to help the flow.
things moving so that things gravity can't win.
Because it's a one-way.
It's a one-way, right? Same thing with the veins. There's not enough pressure. There's nothing really pulling. There's nothing pushing, right? So we have the valves along the way in the veins. Same thing here with the lymphatics. It just prevents things from leaking backwards.
Okay.
So once we get to a certain point, keep going. Okay. Anything else about lymphatic system? I'm feeling more confident in your abilities on this test than the last one. I don't know, cardiovascular is pretty tough. But I think that the digestive and the lymphatic systems are pretty straightforward, just some structures and some things to learn about. And the respiratory system, I'm confident you're going to work through that with great success. So you're going to have a wonderful Easter. You're going to have as relaxing and wonderful time as you can this weekend. I know I should have looked at the calendar more closely and not scheduled an exam right after Easter, but I know you guys can do that. And I will see you all next Tuesday for the exam.